So, good evening, everyone. Hope you are doing well. In today's session, I'm going to talk about the latest updates from the American Diabetic Association guidelines, which were released in January 2025. This is part one of the updates, and this is also my lecture number 86 of my lecture series. Of course, this is an extremely important topic for clinical practice and also a very important topic for several endocrinology board exams. So let's start right away. The first two sections I'm going to cover for is the updates in the diagnosis and classification of diabetes and in the prevention or delay of diabetes and associated comorbidities. So this is a very important chart which we should know so that we can help to understand the guidelines or the recommendations around it. So when we talk about staging of type 1 diabetes as described by the American Diabetic Association, stage 1 typically has characteristics of autoimmunity. The patient is still normoglycemic or pre-symptomatic. In terms of the diagnostic criteria, still there will be presence of multiple islet cell antibodies. The HbA1c may still be normal, and there will be no evidence of any impaired glucose tolerance or impaired fasting glucose at this particular stage of type 1 diabetes. When we talk about stage 2, it is further progression. In addition to autoimmunity, there will be also evidence of dysglycemia. The patient may still be pre-symptomatic. The patient may have presence of multiple islet cell antibodies. The patient may be dysglycemic, having an impaired fasting glucose, which is described as between 100 to 125 milligram per deciliter, or impaired glucose tolerance, which is 2-hour prandial glucose between 140 to 199 milligram per deciliter, or an HbA1c in the pre-diabetic range of 5.7 to 6.4%, or overall more than or equal to 10% increase in the HbA1c from baseline. Moving forward, when we talk about stage 3, again, in addition to autoimmunity, there will be an overt hyperglycemia. The patient will definitely be symptomatic. In many cases, by this stage, some antibodies may become absent, and the diagnosis of diabetes will be by the standard criteria. So, at stage 1 itself, the 5-year risk of symptomatic diabetes is 44%, and it increases to 75% by stage 2. Hence, it is important to try and identify these patients now at an earlier stage so that we can even implement certain medications which can prevent the progression to the further stages, which is part of the recommendation. So, the recommendations suggest in people with pre-symptomatic type 1 diabetes, we should monitor for disease progression using HbA1c approximately every 6 months and a 75-gram oral glucose tolerance test, which is fasting, and a 2-hour plasma glucose annually. We should modify the frequency of monitoring based on individual risk assessment, based on age, number, and the type of antibodies and glycemic metrics. And this is level E recommendation in the latest set of guidelines of ADA 2025. So basically, in individuals at risk for developing clinical type 1 diabetes, younger age of seroconversion, which we are talking about particularly less than 3 years of age, the total number of diabetes related autoantibodies detected, and the development of autoantibodies, especially against islet cell antigen, has all been associated with a more rapid progression to clinical type 1 diabetes. Very important statement, has been asked in the previous exams, and we can definitely expect this in the upcoming exams as well. In this context, while CGM can predict progression to overt diabetes in children with autoantibodies, still OGTT-based metrics appear to be better at predicting progression compared with CGM. Further recommendations, which were part of the section 2 of this update. So it clearly suggests now to screen for pre-symptomatic type 1 diabetes, and this may be done by detection of autoantibodies to insulin, then GAD antibodies, IA2 antibodies, or ZNT8 antibodies as well. So this is very important. They have suggested in this guidelines, in this recommendation, screening for pre-symptomatic type 1 diabetes patients. We're talking here right at the initial stage. Autoantibody based screening for pre-symptomatic type 1 diabetes should be offered to all those with a family history of type 1 diabetes or otherwise known to have an elevated genetic risk. Again, a very important part of recommendation. Having multiple confirmed islet autoantibodies is a risk factor for clinical diabetes. We already saw that in the previous slide. Testing for dysglycemia may be used to further forecast near term risk. When multiple islet cell autoantibodies are identified, referral to a specialized center for further evaluation should be provided. Standardized islet cell antibody testing are recommended for classification of diabetes who have phenotypic risk factors that overlap with type 1 diabetics. Example being younger at the age of diagnosis, having unintentional weight loss, ketoacidosis as a presentation, or needing to go on to insulin within a short time. So, while a family history increases the risk, 90% of the cases can still occur without a known relative affected. Screening for islet autoantibodies in both high risk relatives and general population has been explored in various studies, showing that individuals with multiple autoantibodies have a highly likelihood of developing type 1 diabetes over the next 10 to 15 years. And that's the reason for this recommendation of an autoantibody based screening for those with a family history or otherwise with a known elevated genetic risk. Some other things which I mentioned in this section is factors which can increase the beta cell demand are lower physical activity, high glycemic index diet, high sugar intake. Some of the findings from the observation studies which they have touched upon is the TEDdy study, in which it has been suggested that increased moderate to vigorous physical activity reduces the type 1 diabetes risk in children with multiple autoantibodies. The study suggested higher glycemic index and sugar intake increase the risk of type 1 diabetes progression. So these are some other things to keep in mind in context of this section provided as an update in the guidelines. Again, very important. Why did we need it to do this autoantibody based screening? To try and identify the different stages of type 1 diabetes early. Teplizumab is a CD3-directed monoclonal antibody, and it is approved for delaying stage 3 type 1 diabetes. So it prevents the progression from stage 2 to stage 3 in individuals aged 8 and older. A trial has showed that teplizumab delayed the median time to diagnosis from 24 months to 48 months. Some common side effects included transient lymphopenia and rash, and there are increasingly and ongoing studies exploring additional strategies to help delay disease onset and preserve insulin secretion capacity. Looking at some of the important updates in section 4. So we looked at some of the important updates in section 2 and 3 in those slides. Now moving on to section 4. In this, there were changes specifically made in the immunization subsection to reflect updates for COVID-19, pneumococcal pneumonia vaccine, influenza vaccine, and RSV. And this is the recommended vaccine schedule for people with diabetes. COVID-19 recommended for all 6 months of age and older. Hepatitis B for people less than 60 years of age, and for people more than or equal to 60 years of age as well, based on clinicians' risk assessment. As regards influenza, an important update was recommended for all 6 months of age and older. People greater than or equal to 65 years old, there may be additional benefit from one of high dose inactivated or recombinant or adjuvant inactivated influenza vaccine. The live attenuated vaccine, which is the nasal spray, should not be used. Schedule is annually. As regards pneumococcal, the older vaccine PPSV 23, the update was in individuals between age of 19 to 64. If they have received PCV 13, give one dose of PPSV 23. If they have received PCV 15, follow with PPSV 23 after greater than or equal to 1 year. PPSV 23 is not indicated after PCV 20 and adults who received only PPSV23 may still receive PCV15 or PCV20 more than or equal to 1 year after the last dose. So these are some of the important updates in this set of guidelines regarding the vaccine around this. So, if more than or equal to 65 years of age, one dose is recommended for those who have previously received PCV13. If PCV15 was used, follow with PPSV23 more than or equal to 1 year later. PPSV23 is not indicated after PCV20. Talking about the newer pneumonia vaccines, which is PCV15 or PCV20, again in adults aged 19 to 64 with an immunocompromising condition like chronic renal failure or cochlear implant or CSF leak, one dose of PCV15 or PCV20 is recommended by the CDC. Age between 19 to 64 with an immunocompromising condition. For those who have never received any pneumococcal vaccine, the CDC recommends one dose of PCV15 or PCV20. If you're talking about elderly more than 65 years of age with immunocompromised condition, one dose of PCV15 or PCV20. PCV23 may be given greater than or equal to 8 weeks after PCV15, and PPSV23 is not indicated after PCV20. The updates regarding RSV vaccination was older adults more than or equal to 60 years of age with diabetes appear to be at risk. They may receive a single dose of RSV vaccine. What about Tdap? All adults should receive it. Pregnant individuals should also receive it and have an extra dose. Booster should be every 10 years. What about zoster vaccine? More than or equal to 50 years of age, ADA now recommends to get two doses even if previously vaccinated. So these are the vaccines which we should discuss with our diabetic patients and help protect our people with diabetes. Another update in the section 4 has been regarding dental care. Recommendation is people with diabetes should be referred for a dental exam at least once a year. We should try to coordinate the efforts between medical and dental teams to appropriately adjust glucose lowering medication and treatments planned prior to and post dental procedure period as needed. So, overall, periodontal disease is more severe and may be more prevalent in people with diabetes than in those without, and has been associated with higher HbA1c levels. Therefore, it's important for dental professionals to know when people with diabetes have high HbA1c levels, as this population may have a lower oral healing capacity. And that's why proper coordination is needed. And at times, when certain dental procedures need to be carried out and patient is fasting, we should also take into consideration their medications like insulin and SUs or meglitinides and help lowering these medications to prevent risk of developing hypoglycemia. So as I mentioned to me, the my oral lectures so far is 86. This is the lecture number 86. I have another 85 lectures, which is covering across different uh, topics of endocrinology and diabetes. We have a detailed 8 lectures on thyroid. There is lectures on around all the topics surrounding adrenal gland, pituitary, diabetes sections extensively there, calcium regulation. There are good number of lectures which has high yield topics for the exams, has previous exams recalls, question and answers from exam labs and Oxford handbook as well, and quick exam revisions as well. There is 10 lectures on reproductive system, 2 lectures on lab endocrinology, 2 lectures on genetic syndromes like Cowden and Men, a lecture especially on immune checkpoint endocrinopathy, 3 lectures surrounding lipid management and NAFLD management. So overall, so far, I have completed 86 lectures. So if you do wish to subscribe to my lecture series, you can simply email me at mazirules@gmail.com, or you can WhatsApp me on 055 743 4794. I will leave the details in the last slide as well. Moving forward, section number 5, there has been some important updates there as well. Here, they have talked about the differences between religious and intermittent fasting. So, religious fasting has more of a fixed duration and timing. There is high levels of intrinsic motivation. The risk of hyperglycemia is there at the end of fasting hours with or without ketoacidosis, and dehydration is definitely possible in some types. Whereas intermittent fasting is having a flexible duration and timing, there is variable levels of intrinsic and extrinsic motivation. Hyperglycemia is unlikely as the motive is health related, and there is no added risk of dehydration. There is always an overlap of having an hypoglycemic risk. Risk assessment and education is essential pre-fasting, and treatment adjustment is required. So, in this section, which is section 5, the ADA 2025 has particularly given an update and mentioned differences between religious and intermittent fasting. What is the other recommendation in this section? Again, this section is very relevant because Ramadan is coming up next month. So they have suggested, ADA 2025 has suggested that we should use the International DAR or International Diabetes Federation along with DAR Alliance comprehensive pre-fasting risk assessment to generate a risk score for the safety of religious fasting. And we should always provide fasting focused education to help minimize the risk. We should assess and optimize treatment plan, dose, and timing for the people with diabetes well in advance of religious fasting to help reduce the risk of hypoglycemia, dehydration, hyperglycemia, and or ketoacidosis. So, what is this risk scoring, which is already recommended by the IDF in collaboration with DAR? So you can look at the chart here, which mentions the elements for risk calculation and suggested risk scoring for the people of diabetes who seek to fast during Ramadan. It takes into consideration the classification of diabetes, I mean, whether it's type 1 or type 2, the duration, whether it is less than or equal to 10 years, whether the patient is having already presence of hypoglycemia or not, and what is the level of his awareness. If he is unaware, the scoring is pretty high. It also takes into consideration the level of glycemic management. I mean, if very poorly controlled is more than or equal to 9%. Types of treatment patient is on, if the patient is on multiple daily dose injections or patient is on pump or once daily insulin. How is the patient monitoring the blood glucose in terms of self-monitoring? Does the patient have any complications like DK or HHS in the last 3 to 6 months to 1 year? Does the patient have any other complications or comorbidities, like, for example, in the context of macrovascular disease, like an unstable macrovascular disease, whether cardiac, cerebral, or peripheral? What is the EGFR of the patient? Is the patient pregnant or not? What is the level of frailty and cognitive function? Is the patient work involving physical labor? What was the previous experience of the patient in the previous Ramadan? And whether the fasting hours are prolonged, especially if we are talking about, it may vary depending upon the geographical location. So different scores have been assigned to each of these criterias, and overall, if you look at the risk categories, they have been defined as if score is 0 to 3, then it is considered as low risk, and fasting is probably safe in this scenario. If the score is between 3.5 to 6 overall, it is considered as moderate risk. Fasting is uncertain. If the score is more than 6, then fasting is probably unsafe. And there is always a risk of dysglycemia and complications in this regards. So, a very elaborative risk calculator, as mentioned by IDF and DAR, and now recommended by ADA 2025 as well. Moving forward, what were the changes suggested in the guidelines as regards different medications during fasting? So they have mentioned specifically when we talk about medications like metformin, SGLT2 inhibitor, DPP4 inhibitor, GLP-1 receptor agonist, acarbose or pioglitazone. Remember, all these medications are having a very low risk of hypoglycemia. So if they are taken once daily, then take at the main meal time. If twice daily, split the dose between the two meals. If once weekly, no change of time, especially we are talking in context of GLP-1 receptor agonist. And there will be no necessary to change the total daily dose in this context of these medications, which are pretty safe in terms of hypoglycemia, very low risk of hypoglycemia. What about the new generation SUs, glimpramide and gliclazide? Risk of hypoglycemia is there, but low to moderate. If once daily, then prefer to take at the main meal time. If twice daily, split the dose between the two meals. What about overall total daily dose in this context? Reduce the dose if glucose levels are with within the individualized goal range, and if no other hypoglycemia or hyperglycemia is present at the baseline. What about older SUs like glyburide? Risk of hypoglycemia is high, moderate to high. You should always take it at the main meal only and try to replace with new generation SUs or definitely reduce the dose by around 50%. What if the patient is on basal insulin alone? Again, risk of hypoglycemia is moderate to high. For longer acting basal analogs like glargine 300 or digladic, no need to change the timing. For other basal insulins, take at the beginning of breaking the fast meal. This is what is suggested by the guidelines. What about the total daily dose? Choose the insulin with lower risk of hypoglycemia among the class and reduce the dose by 25 to 35% if not well managed. If the patient is on prandial insulin, risk of hypoglycemia is high, should always be taken at meal time. We should consider reducing the dose of insulin for the meal followed by fasting. For other meals, insulin dose should match the carbohydrate intake. What if the patient is on a mixed insulin and insulin co-formulations? Risk of hypoglycemia is high. If once daily, then take at the main meal. If twice daily, then split the dose between the two meals. What about reduction in the total daily dose? Reduce the dose of insulin for the meal followed by fasting by around 35 to 50%. For all other meals, no change of dose. So these are the changes in medications recommended in fasting by ADA 2025. Now, further updates on section 7, which was dealing with diabetes technology. There are several key updates in this section. So, number one update for CGM is recommended for all people with on who are on insulin. So basically, the guidelines now recommend real-time CGM or intermittently scan CGM for diabetes management to youth and adults with diabetes on any type of insulin therapy. The choice of CGM device should be based on individual circumstances, preferences, and needs. So, what does this updated recommendation simply means? It is clear that now they recommend CGM for people with diabetes who are on any type of insulin, including the youth on basal only insulin as well. Second, consider using RT-CGM or intermittently scanned CGM in adults with type 2 diabetes treated with glucose-lowering medications, even other than insulin, to achieve and maintain individualized glycemic control. The choice of device again should be based on individual circumstances and preferences. So basically, this new recommendation simply means CGM to be used for all adults with type 2 diabetes to achieve glycemic goals because there is growing evidence to suggest that CGM benefits even beyond insulin users. So, very simply, that's the explanation for this recommendation. What about CGM for diabetes during pregnancy? CGM can help achieve glycemic goals, which we mean about time in range and time above range. We can identify with that whether they are achieving the glycemic goals or not. In type 1 diabetics and pregnancy, and may be beneficial for other types of diabetes in pregnancy as well. So simply this recommendation highlights benefit of using a CGM for achieving glycemic goals during pregnancy and eliminates the need of adjunctive blood glucose monitoring via finger pricks. But again, take into consideration the level of recommendation is E. What about the recommendations for the automated insulin delivery systems? Early introduction is suggested. Recommend early initiation, including a diagnosis of CGM or insulin pump and AID, depending on person's caregiver needs and preferences. So the recommendation is updated as of now. Not only CGM but also AIDs systems are recommended at an early stage in the course of diabetes, even at diagnosis. The second recommendation in this regards is regarding the preferred insulin delivery for type 1 and insulin deficient diabetes. This recommendation reaffirms that the AID systems are the preferred insulin delivery method for type 1 diabetics and insulin deficient diabetes wherever feasible. Third recommendation in this regards, especially when we're talking about type 2 diabetic patients, the new recommendation here advocates for offering AID systems to people with type 2 diabetes on multiple daily injections as well. The Omnipod 5 is the first AID system officially approved for type 2 diabetes. Notably, it even has a FDA label for individuals with type 2 diabetes on basal only insulin. So, as other AID systems gain broader approval for type 2 diabetes, we should definitely anticipate further expansion of this guideline. Another update, this update recommended indicates greater openness to open source AID systems beyond previous limitations that discourage healthcare professionals from prescribing these systems. The updated guidance emphasizes providing support and diabetes management advice for individuals with open source closed loop technology, highlighting the importance of collaborative care. What about the safety of AID systems in pregnancy? New recommendation highlights the safety of the AID systems in pregnancy and favors these systems with pregnancy specific targets such as the CAM APS FX and or My Life Loop systems. What about recommendation for the diabetes technology in terms of hospitals? The recommendation is not new, but it reinforces the ongoing guidance for continuing CGM use during hospitalization whenever clinical appropriate, in combination with point of care, which is finger prick testing according to the institutional protocol. Further update in this is to importance of continuing the use of insulin pumps or AID during hospitalization when clinically appropriate and of course in combination with the finger prick testing. What about recommendations regarding digital health solutions and coaching? New recommendations suggest the use of digital therapeutics, digital health solutions, and online programs to help people with diabetes and pre-diabetes by providing even virtual coaching to enhance outcomes. So these were all the important updates in the ADA 2025 regarding diabetes technology, covering the section 7 of the ADA 2025 guidelines. So overall, if we look at the implications of these guidelines in terms of the technology updates, the guidelines underscore the fact that there is now enough evidence to recommend CGM to all people with diabetes on insulin. Consider CGM in people with type 2 diabetes not on insulin to achieve and maintain individualized glycemic targets. Recommend early initiation of AID systems to all people with type 1 diabetes and insulin deficient diabetes, and offer AID systems to even people with type 2 diabetes on multiple daily injections. The guidelines also provide reassurance regarding use of open source AID systems. The use of CGM and AID systems during hospitalization and digital health solution should be always be encouraged to individualize diabetes care. While these guidelines represent important advancements, it is crucial to note that they do not automatically translate to increased access to CGM and AID systems. Many parts of the world are still facing significant barriers such as unavailability of technology, high cost, or lack of reimbursement system. So these two slides summarizes whatever we discussed in the section 7 of these updates from the ADA 2025. Now, that's the end of my part 1 of my ADA 2025 updates. In my part 2, which will be exclusive content for my subscribers, I'll be talking about the recommendations which have been put in section 4 for the management of NASH, or what we refer to now as the metabolic dysfunction associated steatotic liver disease and steatohepatitis. We'll be talking about the FIB-4 scoring. We'll also look at the management options in terms of pioglitazone, tirzepatide, recommendation for thyroid hormone receptor beta agonist. All these will be discussed in my part 2 of the AD updates. The section 8 will be discussed as well, where they have talked about in the recommendation about obesity and weight management. They have discussed in depth for the importance of continuing the monitoring, support, and interventions for the individuals who have achieved weight loss to support their goals in long term. They have also put recommendations for how to screen for malnutrition for people who have lost significant amount of weight loss. Lost significant amount of weight on medications like tirzepatide. They have also mentioned that about the recommendation to consider continuing weight management pharmacotherapy as indicated even beyond reaching the weight loss goals to help maintain the health benefits and to avoid weight regain. So they have specifically mentioned the recommendations about when we stop medications which help lose weight, like the GLP-1 agonist or, for example, the tirzepatide. What are the recommendations in this regards? How to prevent the weight gain in this regards? All has been discussed in the depth in these guidelines. Again, they have made recommendation in the section 9 for using GLP-1 receptor agonists with demonstrated benefits in patients with type 2 diabetes with symptomatic heart failure with preserved ejection fraction. So there has been special recommendation about GLP-1 receptor agonists in this regards. Previous guidelines had recommendation about SGLT2 inhibitors in this regards as well. They have also put recommendations for using vitamin D therapy to prevent type 2 diabetes and discussed about B12 deficiency, which is associated with long term metformin therapy. There is also a section on female sexual dysfunction. And they have also provided some special recommendations which we need to follow in the event of medication shortage. Especially, they have described in section the problem with compounded medications, which was a growing problem because of the shortage of medications in terms of the GLP-1 agonist. And they have also put forward recommendations that in for women with childbearing potential, when should we consider stopping the GLP-1 agonist or GIP agonist when the patient is already on therapy. So all these recommendations will be discussed with me by me on the part 2 of the AD updates. For access to this particular video of part 2 updates, please subscribe to my lecture series. All paid subscribers will be given lifetime access to all my existing lectures, plus all the upcoming new videos. For subscription, as I mentioned previously, just email me at mazirules@gmail.com, or you can WhatsApp me on 0097155 743 4794 for subscribing to the lecture series. Thank you so much. Hope you enjoyed this session.